Good afternoon, ladies and gentlemen. Thank you for coming today. So I'm going to start with a clinical case. I don't have any key pets today, and I know Asians are generally very shy, but try to make this a bit more lively, and maybe we can all keep awake for the next hour. Now, this patient is 81 years old. She's been very, very well, but she's fallen 3 times in the past 1 year. And one day when she was washing the bathroom floor at age 81, she fell down. She slipped and fell down, and then she had low back pain. So her x-rays show a compression fracture at L2. Now, which statement do you think is true? Number 1, you should check her BMD to decide whether she needs pharmacological treatment for the T-score if it's less than 2.5, or just give her calcium vitamin D if the T-score is greater than minus 2.5. Number 2, maybe do an ultrasound of the heel, because that is quite accurate and it would not give her harmful radiation, not like Dexa. Or number 3, her age and fall risk puts her at increased risk of another fracture. Or number 4, there's no need to do any blood tests since she's actually very well prior to the fall. So how many people will pick number 1? Can we have a show of hands? How many people would check her BMD and then decide treatment based on the BMD? Come, don't be shy, okay? See a few hands. Who would do number 2, quantitative ultrasound of the ankle? Clap your hands. Who thinks that number 3 is correct? Her age and fall risk. Ooh, very good. And number 4, who thinks that, don't need to do any blood tests whatsoever. Just give her the treatment. My answer, and of course, not absolutely right all the time, but in this particular case, I think it's that her age and fall risk puts her at increased risk of another fracture. You do not need to check the BMD to know that she has osteoporosis. She's already had a fragility fracture. We do not use QUS of the ankle for diagnosis of osteoporosis. I'll talk about these things later. And you should be doing a few basic blood tests, even if it's just FBC, ESR, calcium, phosphate, and maybe vitamin D levels, or if you haven't done a creatinine for a long time, that could be something you'd want to do as well. So osteoporosis, clinical definition is a fragility, presence of a fragility fracture. So these are very well-known pictures. Normal bone, osteoporosis. You can see that not only are the trabeculae very thin, giving overall low bone mass, a lot of the trabeculae, especially the horizontal ones, are broken. So there's actually very poor bone quality as well. This is a structure with a few very thin broken columns and very, very few beams. So you can imagine this is much weaker than just what the bone mass shows you on BMD. Just to let you know the definitions of osteoporosis, they'll be in your clinical practice guidelines. Don't just think of bone mass and bone density. Think of the microarchitectural deterioration and bone quality as well, leading to fragility fractures. So everybody is very familiar with these WHO definitions of osteoporosis and osteopenia. So osteoporosis, for example, is a T-score of less than or equal to minus 2.5. But if you only use BMD, you will miss quite a lot of people who will otherwise have fragility fractures. As expected, if your BMD goes down, the fracture rates go up, and this is about minus 2.5. And you can see that a lot of the fractures occur at the osteopenia range or even in the normal range. So classification by BMD T-score alone will miss 50% of women with vertebral fractures. They will either have normal or osteopenia on the BMD, and you will miss 1/3 of women needing treatment just using BMD alone. So in this particular study, for example, it's a hospital study of nearly 1,000 women who actually had 132 fractures when the x-rays were reviewed by the study radiologist, but only half of the fractures were actually picked up by the hospital radiologist, and only 1/4 were mentioned in the discharge summary or even mentioned in the record, and in the end only 7% were treated for osteoporosis. So if you do not even as doctors diagnose very severe osteoporosis with fractures, look at all these multiple fractures, then you cannot even treat them. If you do x-rays on your patients, you should look at them yourself and not just look at the report. Anything with less than, with even a 20% reduction in the height is considered a mild fracture if the clinical context is right. And a severe fracture is if there's more than 40% reduction in height. So quite often you'll see that there's something very wrong with the vertebra. You can measure it yourself even if the x-ray report says normal. Clinical pearl is that you shouldn't rely solely on low bone mass as measured by BMD to identify people at risk of osteoporotic fractures. Look at the overall fracture risk, the age, personal, past history or family history of fractures, use of drugs, or high risk of falls. And this is a slide showing the whole picture, not just on bone density, but also to do with genetics, race, your bone geometry and padding, how thin or how fat you are to cushion the fall, how much at risk of falls you are, whether you're on sleeping tablets, have poor eyesight, you're malnourished, you have a stroke or you have Parkinson's, and resulting in a high risk of fall and hence a high risk of fracture. This is a slide showing how falls impact on the risk of fracture. So even if you have osteoporosis and you don't fall, the risk is about 3 times a person with normal BMD. But if you have a recent fall and you have osteoporosis on BMD, then the risk increases to 25 times. If you have BMD and you've fractured a bone before, a vertebral fracture before, the risk of fracturing again is very, very high. So even if your BMD is high and you've had you've had past vertebral fractures, it's 10 times. And the worst combination, of course, is low BMD and a previous fracture. So these are the people at very, very high risk. Low BMD, previous fracture. Now, Dexa is used for diagnosis, prognosis, and monitoring of response to therapy. And in Singapore, we are mainly using Hologic at this moment. But be careful, because some study centers do use the older models like Nolan. You cannot directly compare the BMD results between the two when your patient undergoes scans in 2 different places. And you can tell your patients Dexa is very safe, 1/10 of a chest X-ray in terms of radiation, 100 of a mammogram, less than what you can get just flying long distance. Using Dexa for BMD, the big data that we have, there are population studies on postmenopausal Caucasian women, and they're used on central sites, that means spine and hip. So we don't have too much information about non-Caucasians and non-postmenopausal women and peripheral sites for Dexa. So everything else is largely by extrapolation. Now, the International Society for Clinical Densitometry suggests that we all use Caucasian database. That suggestion is not so way off in terms of Singapore Chinese people. Our risk of fracture is almost the same. Now, if you are premenopausal, you're a man less than 50 years old, or you're a child, it's advised by the WHO IOF to use Z-scores to compare, and a Z-score of less than -2 is then used to refer to BMD, which is less than expected. For children particularly, it's very hard to say this is osteoporosis, okay? But it will help you, guide you in investigating and treating these people. And the other controversy is whether males should use male databases to derive the T-scores of -2.5 for older men, or to use the female database. So there are pros and cons in each approach. When we were preparing the clinical practice guidelines, I heard that the Dexa machine people were all going to program everything to female database. But in the recent IOF course held in February, the slides seem to show that tend to favor the male database. So I don't think this issue is settled yet. Dexa is also used for prognosis. If you have a T-score of about -2, that means the relative risk of fracture is 2 to the power of 2, for example. So in this example, T-score of -3 for an 80-year-old is at least 2 to the power of 3 or 8 times. But in this case, actually, in this population, is 2.6 to the power of 3 or 17 times. But compared to an 80-year-old with a T-score of 0, not compared to a young woman with a T-score of 0. This is because, I think Leonard would like talk about this a bit more. The T-score gives you relative risk, but age plays a big part, for example, in increasing your absolute risk from 1.1 to 5.3 for the same T-score of -2, for example. In this graph, you can see for this same BMD, if you're less than 45, there's virtually no fracture risk. But if you're 80, the fracture risk is 90 times, 90 per 1,000 patient years, sorry. T-scores by themselves have to be taken in interpretation with relation to age and other factors. And Leonard's going to talk more about fracs, but this is just an example. Just key in this woman, for example, 81 years old, and I put in that she has no previous fracture, but parent fractured the hip, doesn't smoke, doesn't have glucocorticoids, no RA, no secondary osteoporosis, doesn't drink too much alcohol, and I can get a 10-year risk score of a major osteoporotic fracture of 40%, quite high, because she's very thin and she's very old. And by putting her BMD in, I can refine this further, and then now she has a previous fracture. And the percentage goes up to 60% over the next 10 years. Of course, these are very big figures because I made her a very thin woman of only 38 kilograms. What about other modalities like quantitative CT or quantitative ultrasound? They're actually not yet recommended for normal clinical use. For QUX, for example, there is good data in research studies that it does predict fracture risk, but it does not yet have a role in the diagnosis or monitoring of osteoporosis in clinical practice. Some examples of Dexa to just show you what are the pitfalls. In this case, for example, there's a lot of osteophytes, so you can see that the T-score will be artificially elevated because the Dexa machine will just measure the amount of calcium per square area. Here, there's also osteoporosis in the hip, but the hip tends to be more accurate than the spine because there tends to be less osteoporosis, but this structure is too prominent. You're seeing too much of the lesser trochanter. The patient should be repositioned and the Dexa retake. Here, there's this condensed kind of vertebra with a very dark area, and you can see that the score is very high, and this is because there's a compression fracture in L2. And here there are calcified ligaments running along, metallic implant as well. You cannot analyze this spine BMD anymore. Here, very good T-scores, and that's because there are sclerotic metastases present in the hip and in the spine. So these are some of the things you can meet in the artifacts that usually increase the Dexa score. Any kind of extra calcium or metal will increase the scores, and in particular osteophytes in terms of osteoarthritis and vertebral fractures. My last few slides. Patient 2. This is a 35-year-old man, and he comes with very low Dexa BMD T and Z scores, and he has a history of inflammatory bowel disease, but only for the first 3 months he required oral steroids, and thereafter he's not been on steroids for the past few years. And he says that he does pass 3 to 4 watery stools a day. And in the legs. So which of the following would you do? Number 1, start a bisphosphonate for osteoporosis. Number 2, start recombinant PTH for osteoporosis. These are the 2 of the recommended treatments for males or for glucocorticoid-induced osteoporosis. Or give caltrate and vitamin D 3 tablets a day, maybe even 4 tablets a day. Or maybe you want to check for secondary causes, for example, 25-hydroxy-vitamin D level, and consider other things like TSH, testosterone, and cortisol. Let's have a show of hands. Okay, I'm going to wake people up for the next talk. Number 1, who will pick number 1? Put up your hand. Start a bisphosphonate. Nobody. Number 2, start teriparatide. Number 3, start caltrate. Few hands. Number 4, okay, very good. My answer is number 4, and this is because this man, okay? So if you are not an expert in osteoporosis, I would suggest you refer to someone who's really interested in osteoporosis. But nevertheless, you know, okay, maybe this is glucocorticoid related, but we are told that he's not really on steroids. So this is a story of malabsorption, really, okay? And this man is likely to have vitamin D and osteomalacia. So osteomalacia by itself will give you a BMD picture exactly like the normal kind of osteoporosis. Why not caltrate and D? I mean, okay, if you've replaced all your vitamin D and normalize everything, and after a period of time BMD is still low, by all means you can treat with number 1 or number 1, for example, but not really number 3, because I think it's too much calcium, although the too little vitamin D. Maybe Leonard might touch upon that later. So this is my last slide. Everything is not just about the BMD. Please consider the patient as a whole. Do look at the BMD scans yourself, the Dexa scans, no other scans. Often patients come to see me with just the front page, and that's not good enough. You have to check for artifacts and technical problems yourself. Thank you.